Hello and welcome back to today's session. Last time we talked about RBC size. Today we are discussing reticulocytes, the single most important measurement for understanding whether an anemia is a production problem or destruction problem. Think of your bone marrow as a massive automobile factory producing red blood cells. Reticulocytes are the brand new cars that have just rolled off the assembly line. They have some internal machinery before they lose it all and become mature RBCs. The reticulocyte count is simply the production gauge on the factory floor telling us how many new cars are being shipped out per day. So, the high gauge reading says the factory is running over time. When the reticulocyte count is high, more than 2%, it means the factory is running at full tilt, likely 24/7. This happens for one of the two major reasons. Number one, hemolysis. The delivery trucks are being constantly destroyed in a massive ongoing car pileup, usually caused by autoimmune diseases like G6PD or hereditary spherocytosis, like we have discussed before. The body senses the low number of RBCs and screams at the bone marrow to produce more of them immediately. High reticulocytes combined with elevated bilirubin and LDH from the cell breakdown strongly indicates hemolytic anemia or acute blood loss. That's the robbery. The fleet of cars has been stolen or lost due to sudden hemorrhage. The bone marrow factory ramps production to replace the lost volume. An RBC leaves the marrow and matures in the blood for about 1 to 2 days. When the production is ramped up during severe anemia, the marrow releases reticulocytes earlier, giving them 3 days to mature outside. This artificially inflates the simple percentage count. For accurate interpretation, we must calculate the reticulocyte production index. If RPI is greater than 2, means the factory is genuinely compensating well, as in hemolytic anemia. If RPI is less than 2 in an anemic patient, means the factory should be compensating, but it is failing to do so adequately. And the low gauge reading, that is, the reticulocyte count is reduced. The factory is stalled. When the reticulocyte count is low, the factory is failing to meet demand. So this is the production problem. The bone marrow is dysfunctional or lacks resources. Resource depletion, as in the missing raw materials. The factory runs out of essential supplies, as in iron deficiency or B12 and folate deficiency, leading to microcytic or megaloblastic anemia. A low reticulocyte count combined with microcytosis points towards iron deficiency. A low RC with macrocytosis points towards B12 or folate deficiency. Or aplastic crisis, factory damage, or in fact a complete shutdown. The factory itself is damaged. This is seen in aplastic anemia. There is the total shutdown of RBC line or following infections like parovirus B19, which specifically attacks the RBC progenitor cells, causing temporary but severe RC drop. The reticulocyte count is not just for diagnosis, it's a dynamic tool for monitoring treatment too. The therapeutic spike when you treat a resource-dependent anemia, like giving B12 to a deficient patient, the factory suddenly gets its material back. So within 10 to 15 days, the RC shoots up dramatically. That's the reticulocyte spike. This spike confirms that A, the diagnosis was correct, and B, the factory is now working at full capacity to fix the anemia. So in summary, when you see an anemic patient, check for the MCV size and then check the RC for production rate. So the anemia with high RC points to the destruction or loss, and anemia with low RC points to production failure, as in marrow or resource problem. Mastering this distinction is the key to nail the initial differential diagnosis in hematology.